Okay, great. Okay, we'll get rolling. All right, we're going to cover spirochetes and Neisseria today. Yeah, there's 3 handouts in the front here if you want to grab them. All right, spirochetes and Neisseria. Okay, that's what I'm going to be covering today. And what I've done now, the way it's set up today, and I'm, sorry, again, ignore the colour scheme. It went off in the part. All of the organisms we're talking about today are gram-negative, and what we've done is we're particularly going to compare and contrast the 2 of the 3 major sexually transmitted diseases. Number 1 is chlamydia, which I'm not covering, but number 2 is Neisseria gonorrhoeae, and gonorrhea. And number 3 is syphilis caused by Treponema pallidum. And so in this first group among the spirochetes, this is basically all concerned with syphilis, which is the major disease among the spirochetes. That's that lot. You'll see there's a lot less for Borrelia, not just because of the fact that it's less common and in some ways more important, which we'll talk about in a bit, but it was more recently discovered. Lyme disease wasn't discovered until around sometime in the 80s. And on the other, so we're going to be covered. So these are among the spirochetes, with syphilis and Treponema pallidum being the most common disease among this group. Since we're also comparing Neisseria gonorrhoeae with Treponema pallidum, at the same time we're going to cover the rest of the Neisseria, and that includes Neisseria meningitidis, which is the number 2 cause of meningitis in this country. It's only a few hundred cases a year, and so it's incidence-wise it's not that great. But in terms of, as I said before, meningitis is a life-threatening condition. And certainly it very often can be lethal. So anytime you're talking about meningitis, you've got an issue here. And this is, as I say, is the second leading cause after Streptococcus pneumoniae, pneumococcal meningitis. This is meningococcal meningitis we're talking about here. So that's the plan of attack. That's why we're doing it this way because we're covering the spirochetes, and among them Treponema pallidum and syphilis, versus Neisseria gonorrhoeae and gonorrhea. And then at the same time, we're covering other spirochetes, and we're covering the other major organism among the Neisseria that causes a totally different disease and has absolutely no relationship to gonorrhea whatsoever. Okay, spirochetes. Now, you've already seen when we talked about Campylobacter, I showed you some pictures of the Campylobacter, and I showed that there could be spiral organisms among the Campylobacter. That's got nothing to do with what we're talking about today. I'm going to show you a couple of pictures of the spirochetes. Spirochetes are genetically a totally unique group that have nothing whatsoever to do with the other spiral organisms that we mentioned. And the only time you're talking about spirochetes is when you're talking about the 3 genera, Treponema, Borrelia, and Leptospira, which are the 3 different groups of organisms that cause disease in this group. Now, there's actually about less than 50 cases a year of leptospirosis, and there's a second Borrelia disease, in addition to Lyme disease, which is also a very low incidence. And so we're going to discuss these couple of things as well. But the biggie again is Treponema pallidum, syphilis. There's something like a couple of 100,000 cases a year still of syphilis, I believe. I think it's about something like the order of a couple of million cases, I think, of gonorrhea, and chlamydia is even more than that. Borrelia is particularly Lyme disease, which is a much lower incidence, but the consequences of getting this Lyme disease are a heck of a lot worse than getting syphilis. So as I said again, not always incidence is not necessarily the case. The consequences are also the problem. So we'll discuss these various diseases. So it sounds like a bit of an odd collection here that we're doing, but you've got the rationale. We're covering all the spirochetes, along with particularly syphilis, and we're covering the Neisseria, emphasizing gonorrhea versus syphilis, and also covering meningococcal meningitis. All right, so the spirochetes. These are gram-negative organisms. They are long, thin, helical, and motile. That's the difference. These I'll show you a few pictures as we go along. These are very long spiral organisms, and they don't look anything like the spiral organisms, other spiral organisms, such as we see, again, an example being the Campylobacter and Helicobacter. And again, they've got nothing to do with them. Just these spirochetes are very different looking and genetically are very different. In addition to them being gram-negative and motile, making them spirochetes, there are things called axial filaments. We've mentioned flagella earlier, and I showed you some pictures of the flagella, how they extend out from the cell. Well, the axial filaments actually look very much like flagella if you cut a cross-section through them. But the difference is they don't extend out from the cell. They actually run longitudinally in the long axis of the cell. And again, they're only found, these axial filaments, in spirochetes. So these are quite unique. And I've mentioned they run between the peptidoglycan layer and the outer membrane. And again, these are typical gram-negative bacteria, so you wouldn't be shocked to see there's a peptidoglycan layer and an outer membrane. And this shows you a picture of Treponema pallidum in a testis-infected rabbit. You see how long these things are? They're nothing like the Campylobacter and Helicobacter that I showed you. So don't confuse, just because it says spirochete, which means spiral, don't confuse it with things like Campylobacter and Helicobacter, just because of the fact that they're also, in that case, being very short and fat-looking compared to these long, very thin things. And there's nothing really else looks like a spirochete. You'll see that it says infected rabbit here. The reason for that is because these organisms still cannot be grown in the laboratory in the year 2006. One of the three major venereal diseases in this country, and we still can't culture the organism in 2006. Okay, so sometimes things just don't happen the way you'd like them. Treponema pallidum is transmitted usually genital to genital. It can also be transmitted in utero or during birth. Now, syphilis is very different to, I think, any of the disease, very different to most of the things we've discussed so far. The word is chronic as opposed to acute. When you use the word acute in any clinical situation, you're usually talking about something that happens in a few hours. Sometimes you might be talking about a day or two. Whenever you use the term chronic, you're talking about something that might take weeks, months, in some cases years to occur or in its final manifestation. This one is definitely chronic. It's a very slowly progressing disease. There unfortunately was a famous case where a group of African Americans were not treated in this country, and for many years. I don't remember the exact date it stopped, but it was a horrible, terrible thing, and they were followed without treatment basically for many years. So anyway, it's a very slowly progressive disease, and the different stages are well known. Now I'm going to contrast this. I didn't put this up here to sort of make you throw up your breakfast or anything, but I'm going to contrast that picture, and I think it's obvious what it is, with the situation in gonorrhea. Okay. Because that is a chancre. Okay, that's an ulcer on the penis there. Now, you're not always diagnose this in a woman of a sexually transmitted disease, and I'm not a clinician, so I'm not going to go very far down that road. But it's much harder than it is in men for obvious reasons, because here the organ is on the outside and the lesion's on the outside, whereas for obvious reasons in a woman, whether it's this sort of lesion or what I'll show you in gonorrhea subsequently, it will be on the inside, and it's hard. So it is harder to see, and it may not always be obvious that somebody has a sexually transmitted disease, and it doesn't always happen that an obvious thing like a chancre. This is called a chancre, by the way, as opposed to chancroid that you'll hear about in Haemophilus from Dr. Gaffar. But anyway, this is referred to as a chancre because it's hard as opposed to the soft chancre that you see in chancroid. Okay. Now there are three stages that are defined in this chronic disease. And again, if it's not treated, it will take years to develop the full features of this disease, and decades even, and it doesn't generally kill you until the final many years after you've had it, or And long before that, you'll have dementia and what have you, probably from the neurological side of things. But there are three different stages, and they're referred to as primary, secondary, and tertiary. And in a primary lesion, which you will see for about 10 to 60 days, there is an area of ulceration and inflammation, and that's the chancre. There are many organisms are present in this chancre, because as we all know by now, the immune response doesn't happen in a day. We're talking about usually weeks with an immune response, and it can sometimes be months. Okay, and this we're talking about here is early on, 10 to 60 days. So the immune response is at the stage here where it's beginning to develop, and it may not have fully developed yet, because it's the immune response that doesn't eradicate this infection. There is no vaccine for syphilis. It doesn't eradicate this organism, but it does slow its progression down. So you'll see a lot of organisms, and that's why I'm going to talk to you about different methods of laboratory-based diagnosis, recognizing you may not always see a lesion like that. So at the beginning, there's lots of organisms. Now, the secondary disease is, again, 2 to 10 weeks later. And this is where the organism has spread from the original site in the vaginal area, where there's been systemic spread, and we see flu-like symptoms, which is typical of the sorts of things you'll see in bacterial infections. And the skin is particularly affected. And there still will be often many organisms present. Now, you cannot say absolutely what's going to happen in secondary syphilis, because it depends when the immune response develops. Okay, if there's been an effective immune response, then the number of organisms would have gone down. So usually there's still many organisms, because the development of the immune response in this disease is fairly slow. By the time you get to the final stages, which is usually going to be several years later, which is very rare, you almost never see, in this day and age, you will almost never see a case in this country of tertiary syphilis. There's absolutely no reason why you should ever see a case of tertiary syphilis, because the person should have been treated. And the antibiotic therapy is very effective in this disease. But there was in the past tertiary cases of tertiary syphilis, and it's in the literature. And so several years later, you will see this form, and it can be affecting the skin and particularly the central nervous system. And this is what's going on here is a delayed hypersensitivity reaction, which is controlling the disease because there are few organisms present. But it's the delayed hypersensitivity reaction that is actually causing a lot of the clinical injury and tissue damage that's going on, particularly in tertiary syphilis. And this is indeed one of the classical types of there are various forms of tissue injury. We've talked a lot about exotoxins. We've talked about endotoxins. We've talked about immunopathology. Well, this is an example of immunopathology where there's actual the cell-mediated immune response is what's doing the damage, because there's not really any there's no toxins really that are important in this disease. Exotoxins. Now, of course, you immediately should have said he must have meant exotoxins, because this organism is a gram-negative organism and does produce an endotoxin. Okay, but there are very few, there just aren't exotoxins associated with this disease. Okay, now the diagnosis is not the same here as in fact in any other bacterial disease. It's quite unique as it relates to this. And in addition to, and why is it unique? Well, because I've said already, these organisms are not culturable. There's been reports that you can sometimes put an organism in a tube of tissue culture media, and you may get it to go through a couple of generations, a few generations, and sort of survive. But really culturable, this organism is not. And it's certainly not culturable ever in the clinical microbiology laboratory. And in fact, nobody would ever even try. Okay? So you can't culture this organism. You use dark field microscopy because this organism, as I've mentioned already, is long and thin. It's not just that it's spiral. It does have a very characteristic appearance under the microscope. But it's very thin, and you don't really see it with regular light microscopy. And just happens to be the way that dark field microscopy works. And I'm not a microscopist, but basically my understanding is what happens is, first of all, the organism is actively motile. So if you don't stain, not only will you see this long, thin organism, which you would not see under a light microscope, but as we see it with dark field microscopy, the organism is often motile, so it will be moving around. It will be using a snake-like motion under the microscope as you look at it, possibly taken, for example, probably taken from the site of a chancre. you'll see the organism is brightly lit against a dark backdrop. And as it states, the light is shined at an angle in dark field microscopy. And so basically, unless the light is reflected off these thin organisms so that it goes into the objective lens of the microscope, you won't see it. Okay, so that's why we use dark field microscopy as opposed to conventional microscopy. You can't see it under conventional light microscopy. I'm talking here without staining also. Now you can, of course, make your life easier for yourself and stain the organism with an antibody against it. But the typical way of doing this with dark field microscopy, the organism would not be stained. Again, conventional light microscopy, the light shines through and you don't see the organism. So this is something different. This is for the treponemes, okay, in general, and particularly for Treponema pallidum. And as I mentioned already, yes, if you use fluorescence microscopy, then in that instance you'll have stained these things so you can see them by green fluorescence, and you can see it a lot easier. And that's, many people prefer to do it this way. It's technically more complicated and more expensive, but it's easier to see the organism in this exudate from the chancre. Now, the problem comes in that certainly in tertiary syphilis, and despite that I said in many cases of secondary syphilis there will be many organisms present, there are going to be cases where it isn't. Because it all depends if the immune response has developed sufficiently well, the number of organisms will go down. So, if you don't get lucky and you don't make a diagnosis very quickly in the first few days by seeing a chancre and going that route, you need a serological approach. And that's why we mentioned earlier the term serology, not again because we really care about the encyclopedia definition, but it's actually used and it's important. And here's an example of where serology is very important. Because we're not detecting antigen again. It's detecting the antibody response, which is much easier to detect an antibody response than an antigen response. If you think about it, there will probably be, if you're talking about antigen detection, there might be microgram or nanogram amounts of the material you're looking at. With an antibody response, you're talking about microgram to milligrams. So it's a hell of a lot easier to detect an antibody response than it is picking up bacterial antigens. So most of the time, except in these weird and wonderful cases like strep throat, we're talking about serology, antibody detection. Now, there are two ways you can do this. First of all is a screening method, where you look at antibodies to cardiolipin. I'll explain a little more about that in a second. The second way, which is much more specific, is to look at antibodies against treponemal antigens, both of which would have developed in the bloodstream of the patient. Now, what happens is this organism, for some obscure reason, happens to be quite a potent adjuvant, presumably something to do with its endotoxins and lipopolysaccharides and where it happens to be. And in this particular, cardiolipin is not a component of the treponeme. It is a component of normal tissue, places like liver, for example. You can just take normal tissues, which are not infected, and extract them, and they will have cardiolipin in them. In these patients, antibodies to cardiolipin develop. It's an autoimmune response, and it could be a feature of the delayed hypersensitivity reaction that we see, and why you see tissue injury. Because it shouldn't be any shock by now that if you get antibodies against the host tissue, regardless if there's any organism there or not, you're going to get immunopathology. But again, it also shouldn't be a shock. If cardiolipin is a component of normal tissues, then one might expect there would be other situations where there might occur an infection and tissue injury would result, and antibodies to cardiolipin might result, and they do, for example, in malaria. So it is not uncommon to see antibodies against cardiolipin, but where they occur particularly and with much higher frequency is in syphilis. So, if you get antibodies, if you detect antibodies to cardiolipin in this disease, it doesn't mean it is syphilis, but it means there's a good possibility that it's syphilis. Now, in those cases where you, and the problem is that it's very cheap to make cardiolipin. I mean, you can just go to a butcher shop and buy some liver or something. But I mean, it's very cheap to study antibodies to cardiolipin. The problem is, as I mentioned already, is that there are some treponemes that can be grown in the laboratory. But actually, if you really want to deal with the treponeme from Treponema pallidum, it's extremely difficult to make this antigen, and oftentimes it is sometimes made from other treponemes. But regardless, it's a much more expensive to prepare a treponemal antigen than it is to just prepare some cardiolipin as an extract. So this is always more expensive. And there are various names that are used. And I've just chosen not to use a lot of those names because there are a number of variants of it. But when you're looking at, not at this course, outside this course, think about what they're asking. Are they asking you about a method that's detecting cardiolipin, or are they asking you about something that's to do with detecting antibodies in the patient's serum to treponemal antigens? So this is cheaper, and it's done as a screening method, and this is a much more specific laboratory-based diagnosis. Sure.
What's the RPR test?
The
rapid plasma reagent?
I've forgotten which one it is. It's one. Well, you can look it up in Murray. I can't remember. As I said, I made a point in this lecture. I was not going to get it. That's what I just said. Yeah. Okay. Okay. Go back. You look at your book and see if it's that one or is it that one. I can't remember. Okay. Go ahead.
You said cardiolipin.
Right.
Part of a normal.
Right.
What is it exactly?
It's a lipid. It's actually found in cell membranes, and the organism grows in these tissues and actually causes the tissues the cells to be, to necrose and get damaged, and so does the cell-mediated immunity. And because of the close association with the organism with the membranes of the cells in which it's growing, it acts as an adjuvant and stimulates antibodies against the cardiolipin. Yeah, I should know the answer to that one. I really have made a point to not. If you look at my handout, you won't see any names in there, but I don't think generally. I don't think they would just use there's a number of different tests, and I don't think you would get just the name. Okay, I think you'd see in there was information that was telling you, something beyond that. Okay, when you take the boards and you get a nasty question and you find out I was wrong, let me know, and I'll start adding the names to the handout. Okay. All right. Autoimmunity. Okay, so we've mentioned cardiolipin. This, again, is a self-antigen. Okay, and I want to stress this because actually I've had a lot of interest in immunopathology over the years, and this term autoimmunity is really used in a very bad way. Okay, because it really is used a lot by people. People will say things like it's multifactorial. They'll say it's multiple possibilities, and the worst one of the lot is autoimmune. If people use the term when they're really saying we don't know what's going on, but this is real. This really is autoimmunity. Okay, there is cross-reactivity. I mean, in this case, there's not cross-reactivity. There's actual antibodies and cell-mediated immunity developing against a self-antigen, cardiolipin. Okay, in some cases, if you really look at what people are saying, you'll say that we never found an organism in this disease. We don't know if it's a virus. We don't know if it's a bacterium. We don't know what it is. So let's call it autoimmune. Okay, and I had from experience because early on in my youth, I did a PhD and 2 postdocs, one of which was in a rheumatology department, where autoimmunity was a big thing. So anyway, that's my personal prejudice coming out here. Okay, but this is real. This is autoimmunity. Okay? All right. There's no vaccine, again, as I mentioned. And generally, antibiotic therapy with penicillin is effective. But again, in clinical practice, you might want to be, some of the other cases, it may not be the case. So you might be, in fact, trying to treat chlamydia, gonorrhea, and syphilis at the same time, and basically trying to cover all your bets. But the actual organism itself is susceptible to penicillin, and there's generally not resistance to penicillin in the treponemes, in these Treponema pallidum. Okay, again, that's about what I want to say about this. I've got a couple of more lines in the handout. And there's a few paragraphs in Murray if you want to go further. But Begel, yaws, and Pinta are caused by organisms that at some points in time have been referred to as Treponema pallidum. At other times they've been referred to as different names. These diseases are caused by Treponema organisms that are very, very closely related to Treponema pallidum. And they're almost unheard of in the United States. And you'll probably never see a case of any of these things. But I mention them for the sake of completeness. Okay. But the big deal here is syphilis, Treponema pallidum, okay? So you'll see that in the handout. I don't really want to say any more about them. Okay, so that was a spirochete, treponema. Borrelia is another spirochete. And those are people who really study this a lot, and I've had my touch with Borrelia at one point, but I don't claim to really work with this an awful lot. There are some differences, but again, what you'll see here is this long spiral-shaped, very thin spiral-shaped thing, typical of a spirochete, and this is Borrelia burgdorferi. Borrelia is a different genus. I actually remember, it's pretty well over nowadays, but I had a long-term interest in reactive arthritis, and I remember very well at the time, I think I actually even heard him speak, if I remember. Originally there was a rheumatologist who was now at Yale, I believe, and he was convinced, he lived in Connecticut, which I think is where Yale actually is, if I remember correctly. Anyway, he'd seen a group of patients that he had just seemed totally bizarre to him. And he talked in rheumatology circles, and people were very skeptical at first. And this was only probably in the 80s, I think. It was in the 80s. And then a very smart microbiologist decided to collaborate with him. His name was Willy Bergdorfer. And it's nice if you get a disease named after you, but any organism named after you. Anyway, the two paired up, and they were able to isolate this organism first. And what was unusual is it was people were going into the woods and hunting and what have you. They would often have a strange rash, which you never see in typical rheumatic diseases. And you can see nodules and what have you, but you don't see an erythematous rash in the typical arthritis patient. And some of them remembered that they had a tick bite, but they weren't always sure because, how often you don't always know that you've had a tick bite. But it seemed to be that this thing was associated with tick bites and hunting. And then what happened was they isolated the organism first from some animals and subsequently from the patients. And this was a very hard thing to do because if you try and make, again, like with syphilis, if you try and make a diagnosis of, a clinical diagnosis, a laboratory diagnosis of Lyme disease, the problem is that you'll be lucky maybe less than 1% of the time in actually getting a primary isolate from a patient. So you're sure not going to use it as a diagnostic test when it doesn't work 99% of the time or more. In the laboratory, you can grow, once you've actually isolated the organism, you can grow it in the laboratory and you keep it going in tissue culture media fairly easily. But that's got nothing to do with making a clinical diagnosis, because a clinical laboratory diagnosis. Because again, it's very, very hard to isolate this thing directly from patients. Okay. Again, tick bites we're talking about here particularly, and that's Lyme disease. Now this shows you the typical erythematous rash that you will see in Lyme disease. That doesn't mean you're always going to see that rash. And it doesn't mean that people are going to know they had a tick bite. Now, this is not just a clinical curiosity here. Okay, well, this is what it looks like, and, maybe we'll see it, maybe we won't. In the real world, it really means something. Again, a tick bite leads to the transmission of Borrelia burgdorferi. Let me explain what this is all about. Okay, now, the problem is this, that the two major rheumatic diseases, and are rheumatoid arthritis and degenerative joint disease or osteoarthritis. They are the two biggies in this country. But there are also a number of much less frequent forms of arthritis referred to as reactive arthritis. And the word reactive means we don't find any infection in that joint, but they have inflammation. That's what reactive arthritis means, as opposed to a septic arthritis. And we discussed septic arthritis when we talked about arthritis mediated by staphylococci in particular. This is a reactive arthritis, one of the thing that's most interesting to people. The problem is that clinically reactive arthritis, even if you do histology, is indistinguishable from rheumatoid arthritis. You can't tell the difference clinically, or unless you happen to get lucky with things like this erythematous rash that I talked about. But the actual arthritis and the histology looks much the same in rheumatoid arthritis and reactive arthritis. And it doesn't matter if the reactive arthritis is caused by the group A streptococcus that we mentioned earlier, or whether it's caused by Shigella and Salmonella, as in the reactive arthritis we mentioned Reiter's disease, Reiter's syndrome, caused by, we mentioned in the Enterobacteriaceae lecture. And it doesn't matter if it's a reactive arthritis caused by treponeme caused by Breeder Gulfurite. They're all going to look much of a muchness. Now, the situation with Reiter's syndrome and rheumatic arthritis is that there's no debate. You don't find these organisms in the lesions, and you don't treat with antibiotics, even though they're initiated by bacterial infections for Reiter's syndrome and for rheumatic arthritis. But the problem is here is you really want to treat with antibiotics. I didn't say you do, I said you want to. And let me explain what I mean by that. First of all, you can see an acute bacteremia. Now, there can be three different things that can happen, and they can go together and they can be separate. And it now appears that some of the organisms in other parts around the world are actually all very similar, but they're not necessarily genetically the same. And there are even people who have started giving subspecies names and species names and what have you. But basically, there are three sorts of features you can see. The reactive arthritis, there can be cardiac lesions, and neurological. Now, if you've got an arthritis, that's really the most obvious because anybody can look at a knee joint or something or a finger joint and see that it's swollen or it's red or what have you. If someone's got neurological symptoms, you're not going to go opening up their brain. So of course it's a lot harder, and they're not always associated together. Sometimes you can see the neurological features without the arthritis. Sometimes you might see the cardiac features without the arthritis. But these things develop weeks to months later, and that's the problem. This is another chronic disease. And why is it a problem? Well, this is the physician's conundrum. If you can treat this disease at the beginning, in the acute phase, it's going to be very successful. If you treat in the late stage, it almost never is. Now, the problem is that you can't culture this organism. So, by definition, the way that you make a laboratory-based diagnosis in this disease, and that's what I just said. Let's talk for early antibiotic therapy. It's curable, and penicillin and tetracycline are used. Late antibiotic administration is very ineffective. Now, the problem we've got here is that so if the person's had a tick bite, if they've had even they don't know they've got a tick bite, and they've got a typical lesion that looks like they might have had a tick bite, and there's somebody that tends to go hunting, which of course is the sort of thing that happens not just in Lyme, Connecticut, where it was originally described, that's what's called Lyme disease, but also in South Carolina. The problem is that if you don't know there's been a tick bite, if you don't see the erythematous rash, and all you see is some of these features that I mentioned that occur later, and the problem is you can't culture the wretched thing. And the thing is that since the organism grows very slowly, like I've already spoken about, your diagnosis is going to be based on serum antibodies. It's a serological diagnosis. And that may take as long as, could be 8-9 months, even longer, before the serological response develops in the patient. So the problem you've got is you like to treat acutely, but you don't know that the organism's there. You don't know they've got Lyme disease. And by the time you find out what's going on, it may be too late. Now, I'm not going to give you an answer today. I don't know what the answer is. It's going to be I'm very interested. I'd like to see it happen. I don't have this problem. You're going to be the ones who have to deal with that problem. I'm not a physician. Okay, well, that is the problem that you're dealing with. And I suppose my only suggestion would be if you think somebody's got Lyme disease, there's some good reason to do it. Treat with antibiotics because it can't do any harm. But I wouldn't say go ahead and treat with antibiotics just as a matter of course, because there are millions of cases of rheumatoid arthritis and inflammatory osteoarthritis, are two of the most extremely common diseases in this country, and it would be an awful thing to do to waste all this vast sum of money on antibiotics. And in addition to that, the problems would be with increased problems of antibiotic resistance and what have you because of unneeded use of antibiotics. So you can't just treat everybody willy-nilly here just because you think because of a few cases of Lyme disease. But if you've got a good reason to suspect that it might be Lyme disease, then the answer is to treat it with antibiotics sooner rather than later. Okay? Yeah. Well, again, there's the arthritis. I mean, sorry?
I thought they were chronic.
Oh, you mean acutely? Acutely, you mean? Not really. I mean, it's sometimes things happen faster rather than sooner. I mean, just because of the fact that typically, it may take a few months or longer to develop doesn't mean that there might not be somebody who things happen to have happened a bit faster. But the major thing is the erythematous rash and the issue of a tick bite. But again, I think what you would also want to think about is if, for example, somebody was hunting, and you spoke to them, they said, well, I'm a hunter, and you said, well, yeah, well, when did this happen? And they said, well, I've been fine for years, and I just went hunting, and it just suddenly happened, I mean, for some reason, that's the sort of scenario that you'd be getting into. But it is a difficult disease to diagnose. When I was at Southwestern Medical School, I did a postdoc in the rheumatology department there many years ago. And since I couldn't get the people in the department to help me, I got permission to go through the charts. And it's amazing with arthritis how you find that the definition changes from week to week and month to month depending on who the physician is. And it's just a very difficult diagnosis to make. Nowadays, for various reasons, it's a bit easier. Okay, but this is a difficult one. Okay? And I think the issue is why is it so important? Well, the thing is that, arthritis is chronic arthritis is pretty nasty. Anybody who's ever, as I said again, most of you in this room have probably got a family member who's had arthritis or has arthritis. And it's not pleasant having chronic arthritis. I mean, you're not going to die from arthritis, but, it's not a pleasant thing. Okay. All right, so etiology, as I mentioned already, it is etiologically, the reactive arthritis is similar to what's seen in Reiter's syndrome and rheumatic fever. But the difference is you don't generally, in rheumatic fever you would treat the pharyngitis aspects that I've talked about, but you don't generally treat somebody who's got rheumatic fever or rheumatic arthritis with antibiotics, and you don't generally with Reiter's syndrome either. And all of them, I said, resemble both clinically and histologically, pathologically resemble rheumatoid arthritis. Okay, now just because we're covering the spirochetes, and no good other reason than that, we're going to mention a couple of other things quickly and then get past them. There's a disease called relapsing fever. There are less than 100 cases a year in the United States. And we've already talked about how difficult the spirochete diseases are to make a laboratory diagnosis on. So you can imagine how difficult it would be to pick up a case of relapsing fever when there's only 100 cases in the whole country, or less than that a year. In this instance, it can be transmitted also from a tick bite, but also from lice. And there are two different species, Borrelia hermsii and Borrelia recurrentis. And basically that's lice or ticks. And it's very, as I say, very uncommon. But it was the traditional Borrelia disease, and I think Murray, for some reason, has chosen to mix the Lyme disease and borreliosis together, because I think what's happened is there was a lot more known about this because it's been known for much longer than Lyme disease. But I don't think anybody would disagree with me that Lyme disease is a much more important disease. Relapsing fever is referred to as relapsing fever, that's the key point, that word, relapsing. The immune response develops, the disease relapses. Unfortunately, this organism goes through, I think I heard Dr. May the other day talk to you about phase variation. Well, this is something similar to that. But in relapsing fever, new antigens are expressed on the cell surface and the old ones go away. So when there's no immunity against the organism, it starts growing again. And it goes through various cycles of this, of growing and stopping growth and growing and stopping growth. And that's why it's referred to as relapsing fever. Well, again, as we've already talked about, we talked about Treponema pallidum, we talked about Borrelia burgdorferi. We said that these organisms are extremely, impossible to grow in the case of Treponema pallidum. For all practical purposes, impossible to culture Borrelia burgdorferi from a patient, although it grows. Once you've got it growing and in the laboratory, it's fine. But again, for practical purposes, actually doing anything about it, you don't culture them. In this case, there's also no culture. And worse than that, there's no serological test. And and again, with the word recurring, relapsing fever, that's why to keep that word in your brain, it tells you just about everything you need to know here, because not surprisingly, if the antigens vary, and they keep on varying, that makes it very difficult to develop a serological test in the first place. And secondly, if you've got less than 100 cases a year, Nobody in their right mind is going to pay anybody to do research on it and come up with to find these antigens and actually develop some sort of a kit. It's just not going to happen. So practical reasons, but knowing the fact that this is a relapsing disease, that's why there's no serological test. Now, in this case, we got lucky. The breeder are a little bit fatter than they're still long, thin spiral rods, but they're a little bit fatter than the other spirochetes. And so you can sometimes see them in a blood smear. And the key word was sometimes there. Okay? It's just not a good way of diagnosing leptospirosis. Okay? All right. I'm sorry. Relapsing fever. Okay. Now there's a better picture here of the third member of the genus. We talked about Treponema, Borrelia. Now we're on to the Leptospira. This is a better picture than some of the others. And you really can see how long these suckers are. And this really long spiral thing. If you go back to the picture that gave you of Campylobacter and Helicobacter, it looks much the same. It doesn't look anything like this. You should never, there's no way you should be ever confusing in your mind this has got anything to do with Campylobacter or Helicobacter. These are the spirochetes that we're talking about, and they're totally unique, and that's all we've talked about so far today, spirochetes. Leptospirosis is about as exciting as relapsing fever. Again, there are less than 100 cases a year, and you'd almost never know that you've even got it because there are not good ways of diagnosing this disease either. Typical of a bacterial infection is there's flu-like features. This can be a severe systemic disease. This is underlined here for this reason, because the key word that we think about leptospirosis is the kidney. The reason we think about the kidney is as follows. For some reason, this organism loves the kidney. It usually is transmitted in infected urine from rodents or farm animals. It gets into the water supply, and somebody typically would be bathing, and they might have a cut or something. Because most bacteria, as we know, do not get in through the skin. It's very hard to get an infection through an unscathed skin. But if the person's got a cut or something, and they're bathing in contaminated water, they can get infected with this organism. And again, it doesn't matter if it's an animal that's the zoonotic host, or it's the person who gets it. The kidney's the big deal here. Okay, so that's leptospirosis. And again, you may never see a case of leptospirosis, but at least you've heard of it. Okay, laboratory diagnosis. Well, in this case, it turns out that serology is also used, but it's not very good. It is the most readily culturable of the spirochetes, but the culture, again, is extremely difficult. So the take-home message here is don't think about culture when you're thinking about spirochetes. Except this being the one exception, and even here, your laboratory in the place that you're at probably wouldn't be equipped to do it. It was something would have to be sent off to place somewhere like DHEC or probably even the CDC. This is not something a regular laboratory would be set up to do. Okay, so that was the treponemes, long, thin, spiral organisms. Now, as I said right at the beginning of the lecture, what I'm going to do is, it's longer than I thought, actually. Wow. Okay, well, I may go on a little bit, I'm sorry, but we'll see where we go. All right, the Neisseria. These are an example of a Diplococcus. We talked about the gram-positive Diplococcus, the pneumococcus, Streptococcus pneumoniae. Now we're talking about Neisseria gonorrhoeae and Neisseria meningitidis. These are gram-negative Diplococci. And we see the importance of the gram stain here. Again, if you've got, many times people will use fluorescence given a chance because it's a lot easier to see things if you stain with a fluorescent labeled antibody, and it just makes things much easier on the eye. They stand out a lot more easily. That's how if you used a fluorescence antibody-based test to detect Neisseria. Okay, so they're gram-negative organisms. Everything today is gram-negative. They're diplococci, pairs of cocci. They are oxidase positive. And that's very commonly done as part of the initial test to sort things out. These organisms are definitely cultured. Now, that doesn't mean that you will culture them, because some labs are trying to set things up. They want to deal with the chlamydia that can't be cultured in bacteriological media. You can't culture the treponines, and these things can be difficult to culture, but they still, they grow pretty well on laboratory media. So sometimes you might just have a molecular biology-based molecular test, simply because you want to deal with the three of them at the same time. But these organisms do grow fine on Phaeomartin agar, which is a selective agar, and it's referred to as chocolate agar, because the blood in this instance is a blood agar where the blood has been heated first, and it forms a brown colour, which is why it's called chocolate agar. And what I mean by selective is that I haven't made this point really before now, but what should I say is not all bacteriological media are non-selective. They're not things like tryptic soy agar and what have you. Because the thing is that if you've got an organism that grows very well, it's not going to be overtaken by something by something else. If you've got an organism that's a bit fastidious and doesn't grow too well, you want to cut down the possibilities of other things that might be contaminating the sample growing. And you might put, for example, specific antibiotics in the medium to try and inhibit other things. And so that's what Phaeomartin is, as opposed to chocolate agar. Chocolate agar would be the regular media that didn't have any antibiotics added to it, for example. Phaeomartin is the selective version of it, which would be really used. So that's what the word selective is. You should know that term, selective agar, selective media versus the non-selective media or agar. Neisseria gonorrhoeae is the gonococcus. Okay, and that's what we're going to contrast now to syphilis, which I said right at the beginning when I showed you that nasty picture of a chancre. Now we're going to contrast the situation with gonorrhea. It's found only in man, and it's the second most common venereal disease after chlamydia. Now that's typically, and again, that's the situation. That's not ejaculation you're looking at there. Okay, that's pus. Now, of course, not everybody that has gonorrhea is going to have pus pouring out of their organ, but that is quite common in gonorrhea. So if you think a person's got gonorrhea and you don't see pus pouring out, it doesn't mean they haven't got gonorrhea. Okay, but if you see something like that, you know what you've got. And again, it would be much more difficult. Even if there was some pus, it would be harder for anatomical reasons to diagnose this in a woman. And what is pus? Well, I remind you, what pus is a secretion of polymorphonuclear cells, and many of the bacteria will be inside these cells, and probably many wouldn't be. But that's typically what pus is. Okay, and this is what you see particularly in gonorrhea. So there should be no confusion. If you were asked a question or shown something where you were compared, and again, we're not saying that every patient with syphilis has a chancre, and I'm not saying every patient with gonorrhea shows an exudate of that type. But if you were seeing something of that type, the chancre is characteristic of syphilis, and the secretion, the pussy secretion, is characteristic of gonorrhea. In this instance, there is very commonly a septic arthritis, and unfortunately, this is the way the world is. We didn't make it this way. Oftentimes, patients with things like septic arthritis will show up in a rheumatology clinic. But if they've got gonorrhea and they've got septic arthritis in this form, they're going to show up in a venereal disease clinic. So different folks, different strokes, they're going to have different experiences in what they deal with. In this case, it is referred to as a septic arthritis because you do find many cases of gonococcal arthritis. You can actually isolate the organism from the joint. But unfortunately, there are many cases that you don't. So one needs to be aware of that. But anyway, this is referred to as a septic arthritis as opposed to a reactive arthritis, where the organism is actually Fortunately, I've got another lecture after this, so maybe we'll have a little break and then we'll finish this now, but we can still give you a break. Okay, and dermatitis is another feature of disseminated gonorrhea. In this case, as I've said to at least one of you privately, this is not an infectious disease course. This is not a therapy course. This is a microbiology course. The only time I talk about antibiotics is when there's a reason from a basic science perspective. In this case, the organism often produces the beta-lactamase, which will destroy many of the cephalosporins and penicillins. The ceftriaxone is particularly the current thing I think is recommended in this disease. And the big deal is that a lot of beta-lactamase is produced for this disease. And that's why resistant strains are common, because they produce these beta-lactamases, which destroy penicillins, for example. Okay, the pathogenesis is not much different than in many of the other diseases I've talked about. There's usually going to be adhesion involved somewhere. And we know with gram-negative bacteria, the two things on the outside are the outer membrane and the pili. So it should be no shock that these things are suggested as being involved in adhesion. There is a lot of antigenic variability in these organisms. And that's why there's no vaccine. There have been attempts to develop a vaccine, because this is a very common disease. So there have been attempts to develop a vaccine, but because of this variation in these outer membrane proteins and pilus proteins, it's been extremely difficult, and there isn't a vaccine. And this is, I mentioned earlier, IgA proteases in my pathogenesis factor, lecture, and Neisseria gonorrhoeae and Neisseria meningitidis are two of the organisms that can produce IgA proteases. Tissue injury. Well, the good news here is, as medical students, you don't have to learn anything about exotoxins here. Okay? It's a gram-negative infection, so people have discussed and postulated particularly both lipopolysaccharide and peptidoglycan as being important in the tissue injury in this disease. And I'm not going to make a decision here which one it is. Depends who you are. Okay, no exotoxin. Okay, that's the big deal. Okay? All right. So that's Neisseria gonorrhoeae. Now Neisseria meningitidis. If I put a picture up here, compare this to the Neisseria gonorrhoeae picture, it doesn't look any different. You can't tell the difference really just from a gram stain between Neisseria gonorrhoeae and Neisseria meningitidis. But if somebody's got meningitis, you sure aren't thinking about Neisseria gonorrhoeae. And if somebody's got a sexually transmitted disease, you aren't thinking about Neisseria meningitidis. Okay, so it's not going to be much of a confusion here as to what disease you've got if you isolate one of these organisms. Neisseria meningitidis resides in man only. There are usually sporadic cases, mostly in young children, these sporadic things, but there can be outbreaks. And I should have added to this list university students, but particularly army barracks and crowded dorm rooms where you see this disease. Now, this is only 400 cases or so a year, which is really not that much more than I talked about with these boring things like leptospirosis and relapsing fever. The difference is if you get meningococcal meningitis, which is the number 2 cause of meningitis in this country, there's a good possibility you're going to die. And so for that reason, there is a vaccine here, and I'll get there when I get there. So the situation is very different here. This is a very nasty organism, a very nasty disease. Neisseria meningitidis infects as an upper respiratory tract infection, and typical of diseases like with Haemophilus influenzae and Streptococcus pneumoniae, we're going to see the organism getting into the bloodstream, using a septicemia and then a bacteremia, a meningitis once it gets into the brain. Again, this is the second most common form of meningitis. That doesn't mean there are millions of cases every year. There's only about 400 or so. But that doesn't matter, because the meningitis is a meningitis, and 400 cases of somebody possibly getting a lethal brain disease is not pleasant. It is fatal if untreated, but does respond well to antibiotic therapy. And this is exactly the same thing that I said about Neisseria gonorrhoeae, so you don't need to learn it twice. Except here we're talking about spinal fluid and not focused on urines or ejaculates or whatever. I think it looked like ejaculates. Again, we're talking about Thea-Martin agar. So that except where you isolate the organism from, you're talking basically the same thing with Neisseria meningitidis and Neisseria gonorrhoeae, just where the disease is and how you isolate it. What is a big deal in meningitis is the capsule. It really is, and that's a fact, because there is a very good vaccine. In fact, apparently they came out with an even better one in 2005. I was just looking up last night. And there's a very good vaccine out there at the moment, and it is a capsule vaccine. Now, again, there's been a problem developing such a vaccine because there are a number of different serogroups, and I've chosen not to name them. There are at least 4 common ones that are out there. This vaccine, particularly the problem I think was one of them, Group B. But anyway, the vaccines now is pretty effective about 85% of the time. And what I understand is, and I think the key word I saw on the CDC site, and I'm not going to go any further with this, is that it's recommended for all school children, and it's particularly recommended, in some cases required, for university students. And I don't know what the military's policy on this is, but I'm guessing it would be a requirement in the military, but I don't know that for sure. But the bottom line is there is a good vaccine out there, and there's the need for universal vaccination, and I think it's already happened in Canada. I don't know if it's what the situation. I didn't see what the situation was in the United States. Okay, so there is a vaccine out there, and you can see why there should be a vaccine, because if you've got a sexually transmitted disease and the person can be treated very well, like gonorrhea, why would you vaccinate 200 million people? But if you've got a situation with like meningitis, where if you don't recognize it and you don't treat it for a couple of days, the person just doesn't recognize it, so they get really sick, and they may well die, then that's a different issue altogether. So I want to get this across because at least one of you was talking to me about when vaccines are developed and why, and that's the point. So you can blame Mary if I keep going on about vaccines in this course.